topics before us this morning, which is Needs for Unhoused Seniors and People with Disabilities panel. We're doing our first panel. I learned from two of my other colleagues doing some fun work in committees and decided I wanted to join in and do a panel in Health and Human Services. So that's what we're doing this morning. Ms. Connolly, can you introduce the topic?
Yes, thank you, Chair. For the record, Mary Connolly, Council staff. Today we have a panel of 4 people to discuss the needs of unhoused seniors and people with disabilities, and I'll invite them at this time to come up and find their seats. I'm going to keep talking. But so in preparation for this panel, I talked to these 4 people as well as other people who work with this population. And in my conversations, I noticed some common pathways that unhoused seniors and people with disabilities take as they bounce between the streets, shelter, hospital, and ideally to permanent housing. So I use this information to develop a diagram that's included on page 12 of your packet today. And Mr. Dominique, if you could pull that up, that'd be great.
And to my colleagues, you have it in your packet at the dais. It's the one that, well, it's a diagram.
Yes, and so I'm going to provide a brief overview of this diagram to acquaint members with some terms that you might hear today. And I'll start by reading a disclaimer at the top of the page, which says, this is meant to be a quick visual reference. It's not meant to be a comprehensive overview of all different pathways that people might take, but it's hopefully a quick reference. And the blue boxes have some notes to provide context and information on potential barriers to shelter and housing options. So starting in the middle of the diagram, you can see streets and emergency shelter. And the Tacoma Rescue Mission and Nativity House are the largest shelters for single adults in the county. And at the last Health and Human Services Committee meeting, Duke Paulson, the executive director of the Rescue Mission, said that about 35% of guests at the Rescue Mission are 55 or older, and over 40% of Nativity House guests are 55 or older. Sometimes unhoused people go to the hospital where there are social workers there to facilitate discharge. So I'll talk about 2 of those discharge options. Again, not the only options, but a common option for people who are ready to be discharged from the hospital and could use stable shelter to continue healing is a medical respite bed at Nativity House. St. Joe's and Tacoma General contract with Nativity House to ensure there are a certain number of beds available, and medical care is not provided, but rather this program ensures that there is a bed available for patients who are referred without having to wait on the shelter wait list. Another option for people who might need a higher level of care are skilled nursing facilities. However, these facilities may choose to decline unhoused patients if they're not confident that there will be a safe discharge plan. And I talked with somebody at St. Joe's who says that they have a program that provides financial incentives to skilled nursing facilities to incentivize them to accept unhoused patients. And then moving on to the bottom of the diagram where you see some common permanent housing options for unhoused seniors and people with disabilities. Adult family homes and assisted living may be options for people who have long-term care needs. Medicaid can cover the cost for these facilities, but residents must pay their entire Social Security check, except for about $100. So that can be a big barrier to some people in accepting that housing option. This also isn't an option for people who are low income and but not low income enough to have Medicaid. So not an option for people who don't have Medicaid. Currently, there are about 855 licensed adult family homes in Pierce County with about 5,000 beds and 22 licensed assisted living facilities with about 1,600 beds. Subsidized housing here refers to affordable housing that's built or operated with public subsidies, where residents must be eligible to rent a unit based on their monthly income. Unfortunately, subsidized housing can have long wait lists, sometimes multiple years long. Housing choice vouchers, sometimes referred to as Section 8, are rental assistance vouchers that recipients use on the private housing market. Between Pierce County and Tacoma Housing Authority, there are over 5,000 housing choice vouchers in Pierce County, but they're pretty difficult to obtain. Pierce County Housing Authority has a wait list for these vouchers that is closed, and Tacoma Housing Authority uses a lottery system. To live in permanent supportive housing or rapid rehousing, residents must receive a referral through the coordinated entry system, and those referrals are prioritized based on vulnerability. And finally, shared housing or sober housing can be an option for people who can find a room to rent. You'll notice that market housing is not on here, and that's because it's usually not affordable to people who have a fixed income, and requirements such as 2.5 times to 3 times the earning 2.5 times to 3 times the rent can be a barrier to accessing those units that are usually unaffordable anyways. Finally, you'll see on the right that at any point along these pathways, somebody may die, and that is true of all of us, but in the U.S., homeless people have a life expectancy of about 27 years less than the general population. And so with that background, again, this is just a summary of what I've learned. These folks are the experts and can talk way more to their experience and these high-level learnings. But with that background, I'm going to move on to talking about the structure of the panel discussion. So staff have asked each panel member to prepare a short intro to talk about their work in the homeless response system and trends that they're seeing regarding the needs of homeless seniors and people with disabilities. And so then council members will have the opportunity to ask questions. I sent panelists some questions in advance that you all had sent me, but you're not limited to those questions. You can ask any questions you want. And finally, I'll introduce our panelists. So first we have Jake Now, the outreach manager at St. Vincent de Paul. Jan Runback, shelter RN at the Yakima Avenue Health for All Free Clinic, which runs out of Nativity House Shelter. Next is Amy Decker, manager of the social work case management department at Tacoma General and Allen Moore Hospitals. And then finally, Ashley Murphy, who is a peer case manager at Catholic Community Services. That's it for me.
Well, I just want to start with a thank you for the work you do every day, both as leaders in your organizations and just doing the job of trying to help us navigate the complicated system and keeping our unhoused population and those seeking services going forward with the limited resource we have. You are very nimble. You do some amazing work and truly saving lives. So thank you for that. We had a couple of presentations that were submitted. Jan, you're going to warn us, like your slides. You warned us multiple times, but those of you that didn't pre-read your slide deck, she did include images of people seeking care. And so just be aware. And so I think is the sequence, we'll just go down the line. Is that the plan? So we're going to start with Jake. Okay. So Jake, and then for all of you, the mics are live when they're green. So all of your mics are live. So if we'll just kind of go down, but when we get to the panel portions of it, just kind of chime in if there's something you want to add. So Jake, thank you for being here.
Yeah, thank you for having me. So yeah, my name is Jake Now. I'm a homeless outreacher with St. Vincent de Paul, and I do some organizing with Common Good Tacoma. My job essentially is, as an outreacher, is I spend about half my time out in encampments, at shelters, at libraries, green spaces, highways, like anywhere where unhoused people are, tending to survival. Bringing folks what they need to survive, because homelessness is a crisis, and that's got to be step one, is to make it to the next day. So about half my time I'm out bringing folks stuff to survive, and by doing that with consistency, you develop relationships with people, and we hope to utilize those relationships to get people to St. Vincent de Paul's Community Resource Center, which is where I spend about the other half of my time, sitting behind a desk, listening to unhoused people and housing insecure folks come in and talk about what they need and how we can help. And so we're using those relationships then to accompany folks into goal fulfillment and what most people want housing, right? But there's a lot of other stuff along the way. Yeah, so that's kind of an overview of what my job is. As far as providing a high-level overview of the trends I'm seeing regarding the needs of homeless seniors and people with disabilities, I'd say a senior citizen, if we're defining it by Denny's eligibility for the senior discount, that 55 and older, right? And people with disabilities, that includes not only those with physical and behavioral health conditions that were a part of their lives before becoming homeless, but also includes the people who experience physical, emotional, psychological, and spiritual traumatization daily due to their life on the street. Those folks whose normal process of aging has been harmfully accelerated by having to daily try and survive outside, and the added infirmities and challenges that result from this. If we're talking about that population, I would say at least 50% of the folks that I see would meet that criteria, maybe more. And trends regarding that population, I just kind of took a bunch of notes. So homeless seniors and people with disabilities are largely from here. This population is not chasing benefits across counties and states. They were housed here and now they were not. Much like every strata of society, on the street there are perpetrators of harm and victims. Seniors and people with disabilities are almost always the victims. Our parents and grandparents get exploited, robbed, beaten, and bullied when left outside. Also, they are way more likely to suffer adverse outcomes from inclement weather, way more likely to need regular and emergency medical care, and way less likely to receive that needed care when needed. I could tell 1,000 stories of our unhoused elders deserving of dignity and care and getting the opposite. Well, we don't have that kind of time. As far as providing information on what systems are working well to address the needs I'm seeing and what are gaps, just again some brief notes. I would say working shared housing models that rent rooms to seniors who do not require like an additional level of care. Like I love seeing that, and there's some good success with that. Some permanent supportive housing solutions, specifically models with on-site staffing and access to medical care. Adult family homes that are population specific, like that's clutch. Prevention, like the ability to find additional income for fixed income seniors keeps folks in the homes. And one of the best ways I've seen that happen, and more often recently, is keeping seniors in their home with family members, or once seniors become unhoused, finding family members who will take their elders in, by providing caregiving income. Like a lot of those folks qualify for caregiving hours, and being able to make family members understand that they can be the people who do that and then receive that income has been a great way to get some unhoused folks housed. As far as gaps, I would say the obvious: there's not enough shelter. There's not near enough shelter. Specifically, there's not enough ADA compliant shelter. In fact, if one cannot self-ambulate, see, hear, wash themselves, or use the bathroom in an appropriate place, they're actually not able to enter most shelters. That's just real. They're on the streets. Those folks are on the streets. There's not enough permanent supportive housing, not even close. There's not, to my knowledge, senior-specific permanent supportive housing, which we have seen some of in Seattle with DESC in particular be extremely successful, and I think that's a model we should look at. The scattered site permanent supportive housing model is the least effective for this population, and that holds true with both seniors and folks with significant disabilities. And then I would say street medicine and behavioral health care are needed more than they are currently available. I know people call my colleague Jan out at all hours of the day and night all the time because there's just not other options, with the exception of the Needle Exchange, who does great work too. Mm-hmm. Yeah, that's all I got.
Thank you. And I'm not sure, do we want to ask questions or go through the introduction of each, and then we'll do the introductions? I think that makes most sense. So Jan, thank you for being here. Thank you, Jake. Is the slide deck going with the introduction for people, Mary? Is that the plan?
There are only 2 panelists that have some slides.
Right, that's why
yes, so there should be a slide deck for Ms. Rumbeck.
And then you'll just say next slide, and Mr. Dominique will move to your next slide.
Oh, I love it. Jan Runbeck, RN. The overview of how I came to this work is as an RN, I joined Medical Reserve Corps, Pierce County Medical Reserve Corps in 2007, which is the volunteer branch of healthcare professionals and logistic folks that are willing to respond to emergencies. It's sponsored by the Tacoma Pierce County Health Department. That was the same year that Project Homeless Connect, Pierce County Project Homeless Connect started, which was an amazing work. It was a coalition. It was run by a coalition then of several service providers that came together and planned for once a year, large event at the Tacoma Dome, a variety of service providers. And so I got introduced to the population of those who are experiencing homelessness at Project Homeless Connect, being a volunteer nurse with providing urgent care and immunizations and things like that. Today, Project Homeless Connect still exists. It is embedded in Associated Ministries. The model has changed. Instead of being a huge once-a-year event, our largest year was 2011. There were 1,645 people that came, because that's all the tags we had. And now it's throughout the county several times a year. So that's been a success. But then in 2017, the city of Tacoma declared homelessness an emergency. And they had a big plan set up, and the first plan was to start the stability site, temporary emergency shelters. Stability site is on Portland Avenue and Puyallup Avenue, and the city of Tacoma asked the health department to have a medical team there to provide any medical services that the folks at the stability site might need. So the health department asked the MRC, Medical Reserve Corps, and I was the lead on that response. There were only 90 folks who were taken care of down at that big tent down there, and it's still down there, and it's not temporary anymore, is it? Right? So after 6 months, the team from MRC decided that this was not an emergency. We pulled back, but we brought in other partners that could provide healthcare services at Stability Site. Then March of 2020, COVID happened, and MRC was activated, 100%. And I will never forget the day that I walked into the health department, and they said that there was an outbreak of COVID at Nativity House, and that there were men in that dormitory, because it's congregate living at shelters, and there were men that were exposed to COVID, and they needed to be separated, and there was no place to separate them. Because in 2017, when MRC was getting involved with Stability Site, there's a group called the Pierce County Coalition to End Homelessness, and that is an amazing group of folks who are service providers, variety of services, and we get together every Friday, and we've done it religiously. And when you get together with other folks who do other things, you learn what they do, and you know how to call them on the phone. So when COVID hit in March of 2020, in 48 hours, I stood up a shelter at Salvation Army Church on South 12th and Union. Had all the wraparound services that we needed, and it was amazing. It was just amazing. So we reduced the spread of COVID by segregating the COVID exposed folks. And we were able to do that until the county was able to access federal money that was coming down, and we were able to get a bigger response. But we got a really quick response for a very vulnerable population. Aggregate living is buggy. Bugs love aggregate living. So in August of 22, MRC decided they wanted to do foot care at homeless shelters, which is fine. So I led that one, and we started Tacoma Rescue Mission, but Tacoma Rescue Mission does not have a day center. They also didn't have access to running water in the area that we're going to do it. And nurses love running water. So that being the case, and having a relationship with Nativity House, we went over to Nativity House and have 4 incredible RNs who absolutely love doing this. It's just really amazing. And the RNs, we do it every week, every Thursday for 3 hours every Thursday morning. And the RNs would be in a room and they would say, you know, Jan, come here, look at this. This guy is not looking good, just not looking good. So it was just a matter of figuring out what was going on with the person attached to the feet, and that they might have a medical condition that should be addressed somehow, somewhere. And because we were kind of successful doing that, I got to thinking, what if we had RNs at the Nativity House 40 hours a week instead of just 3 hours a week? So came up with the pilot project, which we activated fully in November, last November. We are a separate project under Vallejo Vacations. There's 2 of us RNs, and we are there 40 hours a week. Yakima Avenue, healthcare for all. And the goal was to reduce 911 calls, because I'm a taxpayer. 911 calls are expensive. The fire department really liked the idea of having RNs there. So the most recent report we got was a couple of weeks ago that by the 2 RNs being there 40 hours a week, we have reduced the 911 response at Nativity House, which is the #1 site for 911 calls in the city of Tacoma, possibly in the county, and we've reduced that by 30%. The average calls to Nativity House before we got there was 2.25 calls per day. The average expense of a 911 call is $3,525. You got your engine with the ladder, you got your ambulance that comes to do the transport. So do the math. If we reduced the demand on 911 by 30% and the average expense is $3,500, so anyway, that pilot project seems to be working. I'm still working on that, trying to convert it from a pilot project to maybe having us there on a regular basis. Trends. The big trend that I have seen, and I've been in this population since '07, which doesn't mean anything except that I've been around a few corners. The big trend that I've seen in general is that death is prolonged. And I'm not in this population to prevent death. I'm in this population to promote health until people do die. When you have prolonged death, it is messy, it is ugly, it is nasty. You go to the ER way too many times, you go to the urgent care way too many times. You have all these other complications of untreated chronic disease. So the folks that die are typically, in shelters anyway, are typically dying of unmanaged chronic disease. So now we've got people who've had diabetes, COPD, heart disease, failure, all kinds of chronic diseases that are unable for one reason or another to use primary care. So there's an overuse of 911, emergency rooms, urgent cares, things like that. So a big barrier to that is access to primary care. It's a really complicated topic. We could talk about that later. Another big barrier with Jake is extremely aware of, and a trend that's increasing, is sweeps. So those of us that do street outreach, you see somebody, you know what they need, you know who can do it, you go back and they're gone. So the policy of sweeps is detrimental to health. I'm a taxpayer, I get it. It's a complicated subject. Another trend that is happening, though, is the size of the population. In 2000, Pierce County had just over 700,000 people. Now, I just went online, now we've got over 930,000 people. That's an increase of 30% in general population in just 25 years. So even if we kept mental health disease the same ratio, if you've got a 30% increase of a lot of people, you're going to have a 30% increase of whatever morbidity you're discussing, right? So you just have higher trends. The other component that happens is I've noticed a lot of development in Pierce County. When you do development, people that were able to hide and be out of the sight of the public, because they don't want to be in the sight of the public, they don't have any place to hide anymore. You know, we've got incredible hotels and condos and all of that along Theo Foss. That's where folks used to be. So they have no place to hide anymore, regardless of the incidence of morbidity. I've noticed that the people that we see at Nativity House, the older folks, a lot of them entered homelessness in their 50s or 60s. I got one guy that was 85. And they entered it because they did not hold the asset at some point. So I got a realtor there whose wife held title to the house. It was a second marriage for the wife. The kids took the house when she died of cancer. So he ends up being homeless at the age of 55. He comes to the shelter. We were able to connect him with care. He's doing well, although he's just diagnosed with multiple myeloma. But he didn't have title to that asset. I have another woman who was taken care of by a mother's inheritance fund. That fund ran out when she was in her late 50s. She incredible comorbidities. So here she is with us. She doesn't qualify for anything. So the asset, the family structure that held the asset, that family has dissolved, and that asset dissolved. So we call that network poverty, and it's a real thing. The other thing that's happening is that we've got several folks there who were injured on the job years ago, but the job was kind of a gig job. So we got a guy that worked for a major retailer delivering appliances to the third floor of apartments, and he did that for over 30 years. Now he's got an incredible bad back, but because he was employed as a contractor, independent contractor, and not an employee, he has absolutely no benefits, no insurance, no retirement, none of that. So he still has the bad back, and he's with us. I've got several examples of that kind of thing. So a trend I see just in general is that there seems to be an increase in gig work. Well, if you're a gig worker, or if you're an independent contractor or an independent person without the safety net that comes with being employed, and that job is over for whatever reason, you might end up in a shelter someday. Especially since episodic care can keep you alive. You'd be amazed at the number of oxygen tanks we see. So, even these conversion things. So, people have oxygen concentrators in their shelter. You'd be amazed at the number of these patches for diabetic control. And they don't know how to do it, so we put these patches on, and you have on your smartphone, you figure out what your blood sugar is and all that. We had somebody in the shelter who was sent by mail a heart monitor. Now, I'm old enough to remember when heart monitors were things that you strapped on and you lived in for a month and it sent something back to your cardiologist. Now this gluey thing, and I mean, we YouTubed it, right? How to put it on. So we got that. It didn't work because the staff threw away the mailing box. So by the time we got to replace the mailing box, it was already, the data was too old. But he had all the technology, all the wonderful medical technology available to him, but we got this barrier. So what is working is the network of providers. I applaud the Coalition to End Homelessness. Everybody gets together, talks about what's going on in the street, what they see, what they do, what they can do, where the gaps and barriers are. So that is, you've got an amazing group of experts sitting right here. So that works really well. What's not working is access to primary care, because we get a lot of folks who we get into the emergency room then connects them to a specialist. They can't see the specialist because you have to have a primary care person to report the findings of the diagnostic that was done, right? So there's no primary care. There's not enough primary care. We need more primary care to include issues like transportation. I have people that don't go to primary care because they don't have a bus ticket to get there, or they don't have a caregiver that can get them there. So transportation is another thing that is not working really well right now. Also, I think we need better data. 2 years ago, the coalition reported that we had over 300 deaths of folks who had been living homeless. That number is now cut in half, and it's because we don't have good data from the ME's office and from hospital reports. We need to have better data on who's dying, why they're dying, and when they're dying, and what happened to them. So we need better data. We can't address anything unless we have better data. We've got some great data people in the coalition. Garrett Nyland, an amazing data guy, Sally Perkins, all these people. And the number one thing that's not working, and you're going to hear it from everybody, starting with Jake, is housing. Housing. There's a major study done by University of Washington a year and a half ago, who compared 6 major cities in the United States that had the same problems: mental health, drug use, poverty, all the same problems that are stereotypical of what people think of when they hear the word homeless. And the number one problem was housing, available appropriate housing. That's the number one issue. So in the case of the people that I see, it would have to be permanent supportive housing. They just have too many other kinds of issues. But it's time to move to the slideshow. Okay, go ahead and hit the first slide. Be advised, okay, and by the way, Mary Connolly is a wonderful hire for you guys. She is an editor and a commentator on what is too gross to be submitted. Okay, go ahead.
So this is
Next
the
slide.
edited slideshow?
I ran everything through her.
Thank you.
Okay, next slide. Okay, this is street medicine, or in our case, street nursing. So that's a student of mine. I do a lot of precepting for student nurses that need their community health practicum thing. So that's a student looking at somebody that I'm really sure that Jake has met. This is the Hilltop area. People like Sally Perkins call me up and they say, you know, that gal is there. Can you go look at her? And so we do. But we also understand that if you have an open wound that we can address at the moment, it's going to go to cellulitis, which goes to sepsis, which goes to a really nasty, ugly death. So we go there as nurses, and everybody loves nurses, so we get have pretty good access to these folks. But we got to see them over and over again, which we can't with the sweep, but we also can with the mental health condition that's stopping them from seeing preventative care, namely primary care. So this is us in action. Next slide, please. This is the case of a woman at Nativity House with melanoma. She is now resisting care because she probably knows what's going to happen. Right? This is a recent outbreak of melanoma. We will take care of her the best we can. But you know, there are days, most days, I walk into Nativity House thinking, okay, when did I sign up to be an urgent care inside of a geriatric psychiatric unit? I mean, that's basically what us RNs do. So this is untreated probable melanoma, but like Jake talked about earlier, the thing about this particular population is trust. So I can go in and say to everybody, you need to have your COVID shot. They don't care until they know that what I'm saying is represented by other people who understand the consequences of not being preventative or not taking care of a primary care issue. So it's the trust thing. We're going to work on her every day and try to get her in. Next slide, please. Okay, this is a woman who was a bartender all of her life, a bartender at multiple bars around town. You might have met her. But she never had insurance, never had any kind of a 401k, never had any kind of a what do you do when you retire kind of a program. So she had a massive lymphedema of both legs, a diabetic. So she came to us with some pain in her legs, and Catherine starts treating the leg and says, whoa, this is beyond me. We got to get her to urgent care like now, probably emergency room. And as she's treating her, the toe falls off. So she addressed that, the bleeding stopped and everything's fine. And the woman now has waited, even though we did that little intervention, waited so long that the toes are missing. So this is sort of the start of our day. Go ahead with the next slide, please. Okay, there are people in the coalition, like Sally Perkins, who will call and say, you know, there's this guy up at People's Park or wherever, just really is in a bad way. So this is a post. Okay, inclement weather. Jake talked about inclement weather. This is what happens. This is the after picture of inclement weather. The guy loses his toes. He can tell you exactly the winter of when he lost his toes, but there's still a vulnerable site for the infection and all that. That took several visits with us street nurses and people like Jake to say, you know, it's going to be ugly if you don't do something. If you don't do something. Brotherhood Rise ended up taking him into the shelter, worked with him a lot, got him into a SNF, a skilled nursing facility, like Mary talked about the stats on SNF. So he is now safe. He's safe. Next slide, please. Next slide. Is there another slide? Okay, so this is, dialysis. We got 3 people at the shelter on dialysis. Means they got to get transportation 3 times a week to a dialysis center. And if you don't go, if you don't go for about a week, you're dead. And it's a really ugly death. So this is a guy, a lifelong alcoholic. He's a white guy. Look at the foot. This is end stage. He came to us for wound care. He was kind of bounced in and out. He hated the hospital, absolutely hated the hospital. But when he came to us like that, we said, there is nothing we could do for you, and you've got dialysis is not working anymore. Dialysis isn't working anymore. So put him in my husband's car, took him to the hospital. He was dead 10 days later. Okay, next slide, please. A guy that works in yards. The guy worked for a landscaping company, so he rode his bike to all these landscaping jobs, mowed lawns for a landscaper. Was hit by a car on his bicycle on his way to work. Hit by a car. The accident made him permanently disabled. And he was in his early 50s when that happened, permanently disabled. The wheelchair didn't work well enough for him that he was able to get. It was a donated wheelchair. Didn't work well enough for him. He dragged his feet in the wheelchair. You can see that that's a consequence of improper wheelchair. Secondary to a working man's can't even do an LNI claim. So go ahead. Next slide, please. This is necrotizing fasciitis. It is came to us via the respite program, with instructions for the patient to do their own dressing changes. That often doesn't go well. We get a lot of wounds, and it often doesn't go well for patients who are basically mentally challenged in the first place to come to get this level of wound. So we do what we can. Actually, this guy is doing really well right now. And in fact, I'll give you an example. Next slide, please. So this is a before and after. So safe parking is a great concept. I pushed for it a lot in COVID because you really didn't want people in aggregate centers. You wanted people separate, 6 feet apart. So safe parking really made sense to reduce the spread of disease, communicable disease. So this guy was living in his, he was a CDL, he was a truck driver, lost his job during COVID, sat in his pickup for 6 months, developed serious bilateral lipedema, really fat legs especially from the ankles down. That led to a weeping disorder, led to open lesions, went to the hospital, came back. This is a post-discharge from a hospital. Catherine, my other partner, is an amazing clinician. She worked with him, and that's an after picture there. That guy, by the way, just got a job last week, working for a trucking company in an office doing maintaining records for CDL drivers. So, but he still lives at Nativity House until he can make enough money to get out. Next slide, please. There you go. I'm done.
Thank you, Jan. And thank you for Mary for maybe filtering some of those. I'm not sure, but they were really graphic and they make the work that you do very real. So thank you. Amy, I turned mics off because I was getting feedback. So Denson maybe? Nope. We problem solved. Okay, but now my cheat sheet, which was wrong, is not going to help, so, okay.
Well, good morning, committee members. Thank you for this opportunity to share our hospital's experience helping the unhoused seniors and persons with disabilities in our community. I'm Amy Decker. I've been a licensed social worker for over 20 years, and during that time I've worked in hospitals in both Pierce and King County. Currently, I'm the manager for social work case management at Tacoma General and Allenmore Hospitals. Our hospital case management team consists of social workers and nurse case managers who assist patients with navigating the hospital care continuum from admission to discharge. Discharge planning is a complex and individualized process. We have found that unhoused seniors and individuals with disabilities usually require more interventions from our team while they are in the hospital to both support them during their hospital stay and also to arrange for discharge. This population may struggle more with being unhoused or living in a shelter due to higher care needs such as complex medical needs, wound care, IV antibiotics, conditions that require multiple medications, which leads to medications being lost, stolen, or poor compliance, poor ambulation or unable to transfer independently, increased cognitive decline and confusion, and that all leads to increased vulnerability when they're unhoused for financial exploitation, abuse, and neglect. A significant trend is that the hospitals are viewed as a safety net for unhoused individuals by the community, primary care providers, skilled nursing facilities, state agencies like DSHS and DDA. As hospitals, we struggle with this dilemma daily as we try to uphold our mission to provide the highest level of care to our community members. But when the most vulnerable, they don't have a home, but they're medically cleared, our team on the case manager team must share the difficult message with patients about discharging to homelessness. This also creates moral distress for our team who know they are discharging our unhoused individuals to living outside without reliable access to follow-up care and higher risk for hospital readmission. Some patients do become stuck in the hospital when they are too impaired either cognitively or physically to be discharged to the community or even to a shelter respite bed. And if they do not have a legal decision maker, they could also be unable to consent to placement at a long-term care facility. For these patients, their lengths of stay can be extended for weeks to months as we try to locate a legal next of kin, pursue guardianship, which is a minimum of 4-month process, or the patient's conditions improve enough where they can be discharged to independent living again. So now I'd like to share a couple slides that show the data points year to date for Tacoma General and Allenmore. This first slide is a breakdown of those who have been discharged from January to May of this year who were designated as unhoused. And as you can see, the age groups on the side. So we had one person who was over the age of 90, one 80 to 89 years old. And then we had, I can't see the numbers very well from here, I have my sheet, 70 to 79-year-old, we had 23 patients, 60 to 69, 85, or was that 89? 89. 50 to 59, we had 87 patients. And you can see the other age groups. Next slide, please. So for that same group of patients, the 404 patients who were discharged, who were unhoused, you can see how long they stayed in the hospital. With the average length of stay for most patients being 4 days, several left within 4 days, but you can see 147 of those patients had a length of stay greater than 5 days, with our longest stay 73 days. So overall, let's look at what's working well and gaps in the response to unhoused seniors and people with disabilities. First, the staff who work at shelters and respite programs are incredibly compassionate and work side by side with individuals to improve their lives. Their caring and commitment do make a difference for individuals. We have a great partnership with Nativity House Respite Program and have reserved beds that we use regularly to discharge patients. Major gaps, which the others on the panel have already shared, but I'll just reiterate, include not enough shelter beds in Pierce County, especially for single individuals. And there's virtually no immediate shelter options because they're running long wait lists. So if someone's discharged from the emergency department, we can't get them into a shelter that night. We also could use specialized shelter beds for the most vulnerable individuals. There is an example of this in King County where they have a shelter that's just for males 50 and over. Another gap is the slow and complicated process to approve funding for adult family homes and assisted living beds through Medicaid, which we have to first go through Home and Community Services, or DDA, for. And then finally, there are the unhoused individuals who don't have insurance, are not going to be eligible for Medicaid, usually due to citizenship requirements. And we fear this gap will only grow with anticipated cuts to Medicaid. So I'd just like to share a story about a patient who discharged to Shelter Respite Nativity House, which highlights both what's working well and the gaps in our system. So this young adult patient who had profound developmental disabilities had been living in a 24/7 supported living home. But the agency who provided his care sent him to the ED due to agitation and assaultive behaviors. He did not have a medical reason to remain in the hospital, but his supported living agency refused to allow him to return, which made him homeless. His family also declined to accept the patient into their home. He didn't have a guardian to help with this process, and DDA, who had been involved from the start, but could not demand that the supported living agency that they funded accept the patient back. And DDA could only share with us the months-long wait list to access any kind of other support or housing. The patient was in our hospital for 2 months before his behavior stabilized enough that we could discharge him to the homeless respite program. While at the program, he did well and stayed there for the 30-day program. The respite team made accommodations so he could stay in a quieter area and have less stimulation to avoid triggering angry outbursts. He did have a couple assaultive incidents with other shelter guests, but the respite staff were able to guide him to better behaviors and allowed him to stay. Because he was no longer in the hospital and now homeless, DDA could access additional services and find him placement much more quickly than if he had stayed in the hospital, which was considered safe. He ended up being placed in a group home funded by DDA within a month at the respite bed. Unfortunately, he had to experience being unhoused to access services in a timelier manner. Thank you for your time, and I'll be happy to answer any questions later.
Thank you very much. And we're going to finish the sweep here with Ashley. Thank you for being here. And if you turn the mic towards you, it works like, there you go.
Good morning. My name is Ashley Murphy, and I'm a peer case manager at Catholic Community Services. I speak fast. I'm going to really try to slow down, so I apologize. I would like to thank everyone for the opportunity to come before you today. I feel honored to have been asked to speak about this topic. I came to talk about some of our most vulnerable population, our seniors and disabled community members that are struggling to find housing. Housing is a need for everyone in our society, a place to rest, find safety, and gather with family and friends. I provide services funded by Medicaid, which is called Foundational Community Supportive Housing Program. I get the opportunity to assist clients in overcoming barriers that have hindered their ability to obtain or sustain housing, which could include, but is not limited to, obtaining an income, learning how to communicate with neighbors or landlords, finding resources in their local community, learning how to budget, helping them find easy meal prep ideas that they can sustain on their own income, obtaining personal identification documents, and searching for and applying for available rentals. FCS supportive housing services are available to eligible Medicaid beneficiaries who meet health need-based criteria such as mental health diagnosis, a substance use disorder, or complex physical health needs that impact their ability to function independently, and at least one risk factor: chronic homelessness, lengthy institutionalization, and an in-home care recipient with frequent turnover of caregivers or frequent stays in adult residential care or treatment settings. As the price of everything goes up in our economy, so does the price of housing. Some of our community members are unable to afford their own home. They will never be able to afford the fair market rate based on their limited Social Security income, which for most of the individuals I work with, it's around $900 to $1,200 a month. This limits their ability to obtain housing unless they are awarded a subsidy to support them with their monthly rent. Finding housing that these community members can afford is the biggest gap in services that I have experienced when working with these clients. But there are gaps in services after a client receives housing. When these clients finally receive housing, after spending much time in a shelter, they can feel isolated and alone. Some of these folks have bonded with others in the shelter that are also experiencing the same types of barriers and or trauma experiences. So when moving into their own place, they are leaving the community that they built behind. Being able to do things in our community can help give us a sense of purpose and help us to build bonds with others. Providing seniors and or disabled community members a home is just the starting point. It would be great to be able to help these folks not only find housing, but to find a community that they can be a part of. These supports not only bring health and wellness to our clientele, but also help eliminate costs to the community and taxpayers. Some of these supports can and are provided by FCS case managers through our community. Clients who have a community, a mental health provider, a good primary care physician, and have resources in place are less likely to go into crisis and will have a safety net of supports if something does come up. Having a case manager on site and potential housing opportunities could help a client to find activities in the community that they may participate in, have resources that they may obtain, such as connecting to long-term care, finding a new doctor, a local food bank, navigating the bus route to these things would help to support our community to live a healthy life.
Thank you very much. And very clear, but fast, I agree. But I also speak fast most of the time, so I totally appreciate it. So we are now at the question portion. This was a lot of information. I feel like I'm going to have to go back and watch this again. Thankfully, if you are like me, it is recorded and you can do that. And you can do it any time of the day once it's posted on our website. So I'm going to turn this over to my colleagues to see what questions they have, and then we will go from there. Is there anybody who wants to start with the first question? Committee Member Herrera.
Thank you, Chair. Kind of a comment, maybe a question will come up, but Jen, I really appreciate the work that you do. That term network poverty, is that the correct one? I've never heard that term before, but that is a real thing for sure. Some of us have been on the point in time count, and some of that information comes out that, the family got dissolved and they're not part of that family, and now they can't work or they can't provide for themselves and they're out there. And you also talked about some of the trends out there. Is there any trends of folks that are either speak other languages? I'm going to use the term undocumented, because that does happen, and I've experienced that myself going into camps where someone has lived here for 40 years, undocumented, and just worked a physical job, and then now their body doesn't work anymore, and they can't make money, and they don't have a retirement or anything like that. Do you see that as a trend at all? Have you ever seen it come across that at all lately?
Is that question to me?
That's a question to you, Janet, because you're the one that kind of talked about some trends of folks like network poverty.
And Jake might know better about folks on the street, but of folks who might be undocumented, I had one patient at a free clinic that I had who was diabetic, without papers, who refused to go on insulin because he felt that the needles would tag him to be arrested as a drug user. And I'm pretty sure that guy died within just a few weeks of coming to us. He had a blood sugar of over 600. So I think I'm not seeing that particular population. I don't know if anybody else is, because I think they go deeper. They go, and also they probably die quicker, right? So they don't want to be picked up by any system. There's no way to reach them to develop trust, even though the medical system treats everybody. They don't necessarily know that. And so I think that I'm not seeing a trend, but I think it's because they're deeper and deeper hidden. That's my opinion.
Yep. Also, the community first village, or the Good Neighbor Village. Some of the folks you're talking about, they're getting older, they're getting sicker and things like that. That once that village is up, I think is going to help a little bit with some of that permanent supportive housing for end of life, and I'm really excited for that to happen. Because honestly, I mean, it touches me. Those pictures were very calm compared to what's really out there. I've seen what it really looks like. I know what it smells like. And it is not pretty. Those are people. So thank you. Thank you for what you do.
Yeah, I can say too. For sure, I've seen an increase in that population. I wouldn't. I can give an example. Like as soon as you started talking, I started to think about this gentleman that we knew at St. Vinny's from Samoa, who's he worked and was with his family until he couldn't, and then he was on his own, and then he was on the streets a long time, and had no other network that he could connect with. And there was actually, we'd reached out, we'd actually got him accepted in Park Place, which is another great option for folks in this situation. And unfortunately, he passed away maybe 2 or 3 days before that intake. There was a sweep, and he was moved from the spot that he'd been at for probably 2 years, and didn't have what he needed to make it. So, yeah, that population exists.
Thank you. Thank you for all the work you do. Thank you, Chair.
Thank you for the question. Are there other questions? Vice Chair Ayala.
Thank you, Chair. Appreciate it. And thank you, everyone, for not only what you do, but the depth through which you do the work you do, because it's definitely something that takes a lot of will and heart to engage in, and appreciate all of that. Excuse me, I'm a little off my throat today. I think I have a couple questions. One, to just kind of piggyback off of Committee Member Herrera. In terms of our unhoused population that has a life experience that does not have those backup systems, whether that would be those insurances, whether that be those 401ks, whether that be, if they have engaged their entire life's work in something that just does not provide, what percentage of the population would you say lives in that segment?
Of the general population?
Of the unhoused population. And I'll, excuse me, and part of the reason I'm asking is because as I think through what are some of those preventable things that we can help set up structures so that folks do not go into a homeless circumstance and therefore kind of exhaust those resources, I would love to understand what the piece of the pie looks like.
Right. Most of the people that we see at the shelter qualify for some state aid. Most of them have Social Security. Most of them who are disabled enough to see us would do a whole lot better in an adult family home or a nursing home. Most of them will not go because they only get to keep the $100 a month. So, right, it's about $1,000 a month, and they don't want to. You know how much cigarettes cost? You know how much a cell phone costs? You know how much? Just getting by $100 a month. Life is even worse for them by giving up those comfort things.
I actually think it's even less. I think it's $70 that they can get a month. And so that doesn't even pay like a phone bill, right? I mean, and I know that there's the Lifeline program and everything for them, but I would say probably 70% of the people that I serve are folks that if they had a little bit more in Social Security, that they like at least 2 to 3 times the amount, that they would be able to afford housing. Most of the population I serve, are between 50 and 75 years old.
Thank you so much. I did have a second question that I forgot, but it'll come back to me.
Oh, you forgot the
Yeah,
question.
sorry.
Okay. So I'm not seeing any other lights, so I will ask my question, and then maybe the question will come back or someone else will chime in. I wonder about, while I have you all sitting in a dais together to talk together, how beyond the Homelessness Coalition, what are some formal ways that you think we could improve this collaboration or this work so that we kind of can work on kind of undoing this cycle that we see people go from hospital stays to maybe they get some skilled nursing, back to the streets, then back to the emergency room, and then the cycle repeats until, like you said, it's a slow death. Do you have any thoughts on how the system itself could be improved at a county level? Thank you.
In December of 2023, I was doing some street nursing, and on 6th and Pearl in Tacoma, 6th and Pearl, it was inclement weather, which for one thing, we do not have a unified regional approach for the county on what designates, I mean, we're almost there on the definition, what triggers an inclement weather response. So we got real close, and thanks to the county for pulling that together now. And that's been a long time coming. The reason before this is happening, though, so I go out and do some street nursing, let folks know that there are, the buses are free, because the Pure Transit agrees to take folks to shelters for free during inclement weather. So that's a great thing, but it's a bus. There are certain supplies are available, so I'm out there on 6th and Pearl talking to folks, and there's a man with, he doesn't want to talk to me because of the people in the trees behind me. He is black, 56 years old, a veteran with just a tarp on him, and it's going to be 29 degrees that night. I call everybody I knew, Tacoma Rescue Mission van. They've got a search and rescue van that they pick up folks. Different places had vans. Nobody could come to pick this guy up. I go back the next day. He's agreeing to go, but not quite able to get on a bus. He really wants to go, because the first time I called 911 because he was diabetic and bluish. So he refused to go in with 911. The next day he agrees to go. I call everybody that I know of in the coalition. Nobody is available to come and get this guy. And this guy is now not able to do a lot. I go back the next day thinking I'm going to put him in my car. I'm going to take him to the shelter because the city allows for increased bed capacity during inclement weather declarations. And his tarp's not there, and the guy next to him said, he died. He died at night there on 6th and Pearl. 6th and Pearl, 2 miles from my house, inclement weather. So what we can do is the unified regional response is really important to those of us who are out there. Who can we call when fill in the blank happens? So what particular service provider is there that if they can't do it, then we can call the next person on the list. So just making sure that everybody knows what other people are doing, but then funding those services. So we're all lacking funds now, and I am scared to death of what's happening in the other Washington as far as a trend happening. It's going to be ugly if Medicaid is cut back. I mean, we have nothing. We have nothing to fall back on. But anyway, developing the unified regional approach and developing the systems that address that, like transportation, like urgent care, versus increasing access to street medicine by decreasing the number of sweeps, that kind of thing. Why send a van out with a doctor and a nurse when the guy's gone because they've been swept the day before? So just increase communication and recognizing what is working and what is not.
Thank you. Anyone else have something to add or a thought?
I think I can just say across the board, just more affordable housing and then services to help support folks, because we want to pay attention to the housing first model, getting people off the street, especially with these sweeps, but then also the resources to help them sustain it is, I think, tremendously important. I think that's where a lot of us, I don't know about you guys, but like when we house people, they end up cycling back into through the shelters because they didn't have services to figure out how to do it, and they've been unhoused for 20 plus years, some of them, and without the resources to be able to sustain it, it's just a cycle.
Jake, I saw you leaning towards the mic, so I just wanted to see if you had anything, or Amy. You don't have to, I'm just curious.
Yeah, I would agree with a lot of what's been said. Like, you have to stop the harm, so you have to stop sweeps. As simple as that. Senior-specific permanent supportive housing, living wage jobs that folks actually have access to, family supports, and adult family homes that are population-specific. Like a recent example I can give, like a rather heinous sweep example, the city of Tacoma swept a person. I'm sure you guys heard about that. They swept a Cambodian elder, like took the vehicle that he was inside and towed him away, not knowing he was inside there. And that was an on-house person who, for the most part, didn't speak our language. And I wasn't, like, we knew him and we interacted with him every day, and we were not able to convince him of the benefit of an adult family home, because all that he kept hearing was that they're going to take my money, right? And like that's his, despite all the things that happened to him on the street. But we were lucky enough after that happened to visit him in the hospital systems, and an awesome translator came with us, Cylon, actually. I'll say who he is. He's running for city council in Tacoma. Came with us of his own free accord. A common good Tacoma friend hooked us up, and he was able to translate in a way that this person understood. This is what an adult family home is, and like there's a Cambodian specific adult family home we'll introduce you to, and like that happened, and this man who had been on the street for as long as I've been doing this work has, for the last 4 or 5 months, been happily housed in a system appropriate place, in a culturally responsive place, being treated with the dignity and respect that he deserves, right? Yeah.
And I can just add, I think I totally agree with the housing first model that other panelists have talked about. I think key to that is destigmatizing substance use, and that so whatever housing is made available, that meeting the patient where they're at in their recovery, and if they have episodes of return to use, that it doesn't cause them to lose their housing or lose their spot. And that's really, I think, where you see a lot of the cycling back through the system.
Thank you. I appreciate that. Okay. We do have another presentation this morning, so we're going to do the last 2 questions here. The hope is that we will be done with this panel by 11 to 11:05. This has been phenomenal. We probably could have been here for hours. So, but we will go to Committee Member Ayala, or Vice Chair Ayala.
Thank you, Chair. Really, just quick question. In your best estimate, by how much do you think we're undercounting in our point-in-time count?
Boy. Oh, I got thoughts.
I would say 6,000 to 7,000, significantly so.
Undercounting, or so I add what the count is to the 6 or 7, or you think it's 6,000 to 7,000?
Yeah, I would say there's easily 10,000 on-house folks in Pierce County.
Okay.
That are not counted through the point-in-time count?
I would say that's with point-of-time count and without. I'd say at any given time there's easily 10,000 on-house folks in Pierce County. And again, like I don't have data to back that up. Somebody should talk to Garrett, but that's
Right. If you just look at the McKinney Vented data for Pierce County, that number is greater. Unhoused kids is greater than the point-in-time count. And every kid has at least one adult, hopefully.
Yeah.
So, and that was, last time I looked at it, that was just shy of 3,000. So that means just looking at the kid population, there should be at least 6,000. Yeah, so that would be one way of doing it, but adding other sources of data would help a lot.
Thank you.
Thank you.
Committee Member Yambe.
So this question is basically, I appreciate all the panelists and the hitting it home, the messages that we're seeing and we're hearing about, and you're really kind of bringing it front and center and doing that reminder, maybe with a hammer over the head because it's important. I have a question that has some nuance to it. So the state in, for example, like WashDOT has been doing, funds for local governments to conduct. At the core, it's a sweep, and it's saying, hey, we contract through people like, I'm thinking the name, but Common Streets and some other groups to do when they move resident or move unhoused from rights of way, and then basically saying you can, here's some services, here's some available things, we'll try to find you housing, shelter, but you can't stay here. It sounds to me that while there is nuance and differences with just a encampment sweep, that in this context is the same, because it's the moving around, and for example, street medicine, you wouldn't, in the end, you still wouldn't have a location for that person to have medical care sent, because they would be moving around, and it's not like they can say, oh, well, this person moved to this address, because they don't have that. In the work that you're doing, is that that sweep, that with outreach, the same to you as just sweeps when we're talking about sweeps? In that context, are they the same? Okay.
That one is done by name. They do it by name list. So when sweeps happen, sweeps just categorically move everybody that has a tent out. But that one that you're talking about is by name, so there's a real effort to keep in touch with that person. So yes, they are swept, but they know the name. They kind of know the area that they're going to. There's other people that can speak better to this. But a by name list is a different approach to tackling homelessness than the general sweeps or just street outreach in general. I know I don't, and unless I need to do follow-up with somebody, I generally don't take somebody's last name or their date of birth, unless I'm actually going to do some care coordination. But the trust isn't there for folks to give their last name or their legal name for a variety of reasons. So that particular sweep is successful because that part of that population is able to fit into that system. The other way to understand homelessness is that typically when people enter homelessness, they live in their car. They don't see themselves as homeless, but legally they are homeless. They live in their car. So there was a major study by a researcher, Dr. Pruitt in University of Washington, that did a lot of research in King County specifically. 50%, he determined that 50% of those who are experiencing homelessness lived in a car. So if we're looking at bodies on the street and in shelters, and 50% of the people who have no permanent address, they're in their cars on our streets throughout the county. So that is another large hidden population. It's also the population that has the highest success of getting back on their feet because they just left being housed. So there's a big difference in when we talk about homelessness, living 20 years less. The chronically homeless have a shorter life expectancy. Those that have a shorter experience of homelessness, their numbers of expectancy get better. So when you can catch them when they're newly homeless, like in a car, then they have a much better long-term outlook.
Yeah, if I can address the right-of-way project, yeah, I would say that's different. That's something different than what the HEAL team for City of Tacoma is doing. I think it's, like, theoretically, it's the only way to do that. Like, it's not ethically okay to show up and tell someone to F off, and you're going to throw all their stuff away. But this isn't that. This is theoretically what's supposed to happen is that there's weeks of outreach that's happening beforehand, and those outreachers are learning who lives there and who's a resident and like who's a resident of this spot, because that's what it is at an encampment, right? Like that becomes your home. And so they're finding out who is there and they're making a list. And then like through, again, it's all based on relationship. It's through that relationship they're offering, hey, you don't have to just leave when we come and clear this encampment. You can go into housing, you can go into shelter. Like there's things that you can do and we will work with you. And so a lot rides on that outreach connection. Yeah, so it's a totally different thing. And if it's not done effectively, if that outreach team isn't there spending the time getting to know those folks, if that outreach team has never showed up at that site before, the results show that, right? So it's really important who that outreach team is. And I would offer that it shouldn't just be one team. I would offer there's different ones of us who like focus in different parts of the city and in different parts of the county. you know, like, and if this is a county-wide initiative, which it is, it's actually a statewide initiative, right? Like, you should be using the outreach teams that are population specific, and that's how you're going to have your best success. Like the folks who are going to already have relationships with certain outreach teams and trust those folks. So, yeah, it's something totally different than the HEAL team, which I'm always going to put in quotes, ain't healing shit. But there we are.
Thank you.
Thank you very much. Ashley or Amy, do you have anything to add to that question? I'm not sure if you do, but I just want to make sure. Okay.
Thank you.
Yeah. So I just want to extend, again, a thank you for coming and spending so much time with us this morning to help us kind of think about how we can do this. I heard a couple key takeaways. So one, housing. We all heard that multiple times, and we've been talking about that as a council for quite a while. I think the type of housing was interesting. So I don't know that we've thought about specifically looking at building housing for senior and aging populations, especially permanent supportive. We've talked about permanent supportive, but we haven't talked about the kinds. And so I think that's an interesting conversation to have as we think about where we're going to invest. I think the other thing, I was excited to hear that there's interest in work, and I'm going to remain very hopeful on our unified regional approach, this idea that we can work together. And I hope all of you or maybe your organizations are going to help us work on what does that look like. Unfortunately, the first meeting of it for one of our stakeholder groups was literally during this meeting today. But we know that there's a lot of interest there, and I think that there's energy around that. The other thing I heard loud and clear is that if we can prevent people getting to the point of needing extended hospital stays, having chronic conditions that go untreated, unchecked, those health conditions do not lead to that slow death and cycling through systems. And I don't know what that looks like, and I'm not sure how to solve it, but it was good to hear it today that it is something that we could be thinking about. So I appreciate you all being here, and thank you for your time this morning. I'm going to ask that we applaud them because they did a lot today. So. Thank you.